Given the times that we are in, a time filled with uncertainty, especially when it comes to health, it is imperative that we make our voices loud in the co-creation of our health, right? The announcement of the GOP's plan for our healthcare provides a perfect example for why the local will matter more and more to fill in the gaps that many sick, poor, and elderly will fall through in the coming days. So I come to you today, as many of you, wearing several hats. I'm a newly appointed professor at the Department of Health Management and Policy at University of Michigan, with expertise in health policy, social movements, and knowledge production, using sickle cell disease as the lens to explain how these things are in tension with each other. But before this, I served as a health scientist in the Division of Blood Disorders at the CDC for almost a decade, serving those living with hemophilia, thalassemia, and sickle cell disease with partnerships via national organizations. And before all of this, I was born with sickle cell disease. So in studying sickle cell disease from the government's perspective, a researcher's perspective, and my very own personal lived experience, I have seen the tensions between power, legitimacy, and efficacy in many realms. So currently, I study how the local, specifically social health movements in Brazil for sickle cell disease have led to policy change on the national level. This was done through policy processes that were embedded in the Brazilian Constitution. Physicians worked to ensure that every citizen was guaranteed health as a right. Imagine that. Further, the state mandated that individuals from disease-based organizations like sickle cell disease had to sit at the proverbial table for the development, maintenance, and evaluation of health policy. This came out of a really good and progressive place. But amidst all of this, for me, a troubling was simultaneously taking place between the claims being made of those living with sickle cell disease and those who were served to distribute health rights. What was taking place is what I call bounded justice, an attempt to distribute health rights without disturbing the underlying mechanisms that generated initial inequalities among those sitting at the table to begin with. Even though these citizens were at the table, they still weren't really being heard. In essence, the acts of justice are bounded by larger societal, systemic, and structural factors. Things like social and cultural and political capital, racism, politics, access to education and income. It's with this in mind that I think about engagement. So let's start with the local, which is never really singular, right? The local consists of a network of actors, and as you can see, is not a linear model. But we tend to want our evidence to look and be linear. As Rebecca Ango, one of the group facilitators, said in earlier communication in our work stream, there is a need to prove that engagement improves outcomes, but how is that process couched? All of this is embedded in larger systemic processes of power and legitimacy. The charge today is to take an aspirational and visionary approach to co-creating our health, to envision a world we want for ourselves. So I'd like to push you to think about how engagement could be transformed if we approach it from a systems level. I listened to the tail end of the first day of the All of Us videocast on Monday and heard frustration from some about the lack of community accessibility for the data generated from projects. So how do we navigate the tensions between what is deemed historically legitimate by the standards of science in terms of data collection and reporting, and what we are called to do to shift how engagement works from top to bottom? This means understanding that the ways of knowing can't always be standardized. If we want to honor all of the voices involved in the engagement process and want to learn how to better bridge the local with the national, we must be prepared to question what is valued on the systems level. This means we push against the norms of how data is collected and how data is reported. We understand that in valuing all voices, we must reach beyond a purely biomedical construct in the ask. When working with the narrators of my research project, I recognized that these communities' own activist efforts were steeped in the assertion of their personal and political identities. And thusly, it was incumbent upon me as a researcher to embrace a methodology that would be attentive to the nuance of individual personhood and collective memory. By utilizing oral history as part of my data collection, I centered the voices of the community. and allowed for representatives that might not be foregrounded in typical public health work. I use these voices to tell a wider story about policy development and embodiment. This kind of methodology, I understand, is not one easily applied to many research initiatives, but I bring it up to make a point about intentionality. I am intentional about marginalized voices being added to the archive as contribution to the scholarly conversations about race, ancestry, and policy. It is unwise to assume that only geneticists can contribute to these conversations. The advocates I met were indeed quite savvy about their genetic profile and its utility. I work to be intentional that there is reach beyond the ivory tower. Yes, the currency of the Academy is peer-reviewed publications, but it is of equal and greater value that you create products that can be of use to the very communities that gave themselves to you. For me, this means the creation of products available for those in the sickle cell disease movement in Brazil. Audio, video, and image archives, accessible text in Portuguese. There must always be an intention of reciprocity, and hope that these products further empower a community to build social, political, cultural capital. I know that great work is being done in conceptualizing the return of value to participants, but how do we begin to normalize the valuing of the patient themselves? How do we normalize the presence of underserved populations at NIH meetings? How do we normalize discussions about social, political, and historical forces at every step of the research plan? How do we dig deep and call out our own and other biases at every step of the research plan? National entities can learn a lot from their local counterparts for some of this work, many of whom are keenly aware of the societal balance and call them out. The larger you get, however, the harder it is to not contribute to the problem, as capital building, power shifting, and legitimization have likely taken place. Act Against AIDS is an initiative launched by the Centers for Disease Control and Prevention and the White House to combat complacency about HIV and AIDS in the United States, and has figured out a way to be inclusive in their efforts. I use this just as one example, and of course I go back to my roots from CDC. And Act Against AIDS is a national collaborative that is actively working with partners that may or may not have anything to do with the HIV/AIDS community. And what's unique about them and creative about them, I think, is that they're utilizing these partners to create and tailor a national standard of education and materials, and then they take that and they use it for their particular audience. It doesn't sound like it's a novel approach, but the idea that the collaborative reaches deep into places like the National Urban League, the National Hispanic Medical Association, the National African American Tobacco Prevention Network, people may not be connecting tobacco prevention with HIV prevention. But the point is that some of the constituents are absolutely blended throughout all of these partnerships, and to be able to use materials and then tailor them specifically for your needs is a way to continue to get the information out. So I'll end here in saying that if we are truly interested in co-creating our health, it's going to take the voices of all of us and will be a slow and messy process. Even slower and messier, given that the national may now be imagined as extremely hostile. We must continue to be creative in our inclusivity, and we must be well aware that it may cost us, and do it anyway. I look forward to the conversations that will occur over the next 2 days around this important charge of co-creating a healthy future. Thank you.